today's discussion, let us start with something which has been asked. Every university likes to ask questions based on pneumonia, and which is very valid because pneumonia is something we come across. If you're an intern, if you're practicing medicine, if you're seeing patients as an MBBS or an MD general medicine or beyond that, also you will come across pneumonia very frequently. If you enter the ICU, there will be pneumonia patients there, and therefore even most universities across the country will ask questions based on pneumonia very frequently as long essays, if not short essays or short answer type questions. So pneumonia is important both from exam point of view and practically also. So that's why I felt let's start with this topic first. So getting on with our discussion, number of previous questions which I have gone through at different universities, which have in one form or the other asked about pneumonias, especially community-acquired pneumonias. As recently, if I take the example of RJHS, as recently as last year meaning this year's university exam, the last university exam that happened in Rajiv Gandhi University, also has asked a 10 marker based on community-acquired pneumonia. So likewise, there are a number of other universities which have been asking questions on pneumonia. So it's not so it's quite obvious. That the topic itself is very important. Some other questions based on pneumonia could be differential diagnosis of pneumonia or types of bronchial breath sounds, which of course one of the types of bronchial breath sounds is tubular bronchial breath sound, which is heard in pneumonia. And there is always a scope for asking questions based on ventilator associated pneumonia, which is very important from ICU management point of view with regards to hospital acquired pneumonia. And CBME themselves have given importance to something called aspiration pneumonia. So there is scope to ask questions based on aspiration pneumonia, ventilator associated pneumonia. So we'll try and discuss a bit about all of these in today's session. So this was a question earlier this year in the university exams, where a patient had presented with cough and fever since 5 days, expectoration, dyspnea, and blood pressures being low. So eventually the question was discuss the diagnosis, describe the management, and describe the CURB 65 criteria, which I'm sure all of you have some idea about answering all of these questions in one way, in some form, but we'll try and refine those concepts today. So I'll just highlight what CBME wants. CBME has outlined the internal medicine curriculum in terms of competencies. There's one entire competency devoted to pneumonia, and that is the IM3 internal medicine. Third competency is entirely for pneumonia. So in terms of the knowledge domain, so all these are knowledge domain based topics, which means they will be tested in terms of theoretical questions or theory questions. So again, so the emphasis on community-acquired pneumonia, no doubt, but also nosocomial and aspiration pneumonia. So all of these could be potential questions: nosocomial pneumonia, aspiration pneumonia, and then the various etiologies for pneumonia, and depending on the risk factors, including the immune status and the natural history and complications of pneumonia, apart from the clinical features, enumerate the indications for hospitalization and what is isolation, the indications for isolation and barrier nursing, and finally the oxygen support that needs to be provided and the ventilatory support that also needs to be provided for patients with pneumonia. This is what CBME wants. So, and that is why we need to be prepared for questions based on these. So getting on with the topic per se, pneumonia, as all of you would know, it means infection of the lung. We always take it as infection of the lung, but it is not strictly so, right? It could even be non-infective inflammation in the lung. So basically there is an inflammation within the lung. And when I say within the lung, it could be mainly involving the alveolus. It could be mainly involving the airways leading to the alveolus. So it could be the airways, which then end, the respiratory bronchioles end in alveoli. It could be the airway, it could be the alveolus, or it could be the interstitium. So if this were to be the blood vessel, which carries the oxygen from the alveolus into the heart. Now, if the interstitial space, if the framework on which both the alveolus and the blood vessel rests, if that interstitium gets infected or inflamed rather, that is also counted as pneumonia. So pneumonia basically means inflammation within the lung. Somewhere it will predominate. So it could be predominating in the alveoli, which means in terms of structure, if there is predominant inflammation in the alveolus, we call it as lobar pneumonia. If there is predominant inflammation in the airways, we call it bronchopneumonia. Likewise, if it's predominantly in the interstitium, we call it as interstitial pneumonia. That's how structurally one of the ways to classify pneumonia. But basically, it is inflammation. This inflammation could be tubercular also. So if you are wondering whether tuberculosis is a cause for pneumonia, yes, it is. That is also an infective cause of inflammation in the lung. Sometimes it could all be not infectious, could be non-infectious causes of inflammation also, in which case the examples could be, for example, chemical pneumonitis, especially because of gastric contents. So right from the off, if I could ask a question, what is Mendelssohn syndrome? If anybody wants to answer that, whether in the chat or whether wants to unmute, can they unmute, Kishan?
Yes, they can unmute and answer.
Okay. Anybody wants to answer what is Mendelssohn syndrome? Have you come across that term? You will, if you have not come across, no problems. You will come across it, especially both in surgery and in anesthesia also. It's basically when a patient who's been taken up for an emergency surgery, sometimes the last meal wouldn't have been long enough. That gap between the last meal and being anesthetized would not have been long enough. So there still be gastric contents, and that can get aspirated, and that can produce, even if it's not infectious, it can still produce pneumonitis, chemical pneumonitis. That's Mendelssohn syndrome. Right, so it need not be, or sometimes even volatile poisons like kerosene, especially in children. So kerosene poisoning, it's a volatile compound, so that can end up entering into the lungs and produce inflammation. That is also a non-infectious cause of pneumonia. Drugs can produce pneumonitis. So lot of times the non-infectious causes are just called as pneumonitis, but they're interchangeable, pneumonia and pneumonitis, just a matter of whether it's infectious or not infectious. So pneumonitis due to drugs, for example, methotrexate, amiodarone, these can cause pneumonitis. These are all non-infectious causes of inflammation within the lung. Right. So in terms of classification, I told you already, structure-wise, it could be either lobar in the alveolus or bronchopneumonia, that is mainly in the airways. Not to say that it's only in the airways, but it's predominantly in the airways. And then interstitial. So interstitial pneumonia will be in the framework that supports both the lung parenchyma as well as the vasculature that's trying to take away the oxygen from within the alveolus. Right. Other ways of classifying is, where did the patient acquire the infection? If it is an infection, where did the patient acquire it? Whether it was in the community setting, whether it was within the hospital, or was it a healthcare related or healthcare associated pneumonia? So community acquired pneumonia is basically a person in the community ends up getting an infection, and that is community acquired pneumonia. So the word term itself is self-explanatory. Whereas nosocomial or hospital acquired pneumonia, it's also called hospital acquired pneumonia or HAP. This is when the person has been hospitalized and at least stayed within the hospital for 2 days, following which the person develops a manifestation of pneumonia, any hospital acquired infection for that matter, whether it's pneumonia or urinary tract infection or any other infection. If we want to attribute it to be because of hospitalization, then the person should develop it beyond 48 hours of hospitalization, which means when the person was admitted, he or she should not have been even in the incubation period for such an infection. Okay, so if the person was deemed to not be even in an incubation period for a community acquired infection and then developed a manifestation, for example pneumonia, an infectious manifestation like pneumonia post 48 hours of hospitalization, then we can attribute it to be because of hospital acquired infection or hospital acquired pneumonia, which is also called nosocomial pneumonia. Right. So same way, there is something called ventilator associated pneumonia. Ventilator associated pneumonia is post intubation, post being connected to the mechanical ventilator. And this also, the patient should develop it beyond 48 hours of intubation. So this 48 hours time duration is important. The person should not have had even the prodromal symptoms or prodromal manifestations, nor even the incubation of these infections before the manifestation started. So you should have that much of clarity before you attribute it to either the ventilator or the hospital in general. Okay, healthcare associated pneumonia is a little dicey. Harrison itself, it's given that maybe this particular terminology needs to be done away with. Why it came in the first place, I'll just tell you. Healthcare associated pneumonia, the term came into practice because anybody who had been, so to say, recently exposed to healthcare, maybe in the form of a hospital, maybe a person who's undergoing dialysis, maybe a person who received antibiotics. So anybody who has had a recent healthcare exposure, not to say just healthcare, sometimes even nursing homes or old age homes also. So if the person has been there and then developed a pneumonia, it was highly likely, it was thought that it is highly likely such patients will have an infection because of a multi-drug resistant organism. So that is why this healthcare associated pneumonia terminology had cropped up in the first place. It's not universally been done away with, but of course there is a uh, little bit of controversy regarding it. But what you should especially know is community acquired pneumonia and hospital acquired, especially ventilator associated pneumonia. Okay, so we'll start with the community acquired versions. I already told you lobar pneumonia is the classic. You've all heard of consolidation. You all know what, at least you've heard of the term called consolidation. Consolidation, so basically indicates some solidification, right? So if you think about it, the lungs are quite hollow, in the sense they have a lot of space within it. The lung parenchyma, we say lung parenchyma, but that alveolus is a minor part of the lung. A lot of space is really occupied by air, right? So the airways allow the air to pass through it, and the alveolus, of course, will allow for the gas exchange to occur. So all this space, all this free space, if it ends up getting occupied by something, then it will lead to solidification of the lung. So consolidation is the solidification of the lung. What is it that is occupying the usual free airspace in the lung? It is exudates. So exudates, when they end up occupying inflammatory exudates, when there's inflammation in the lung, if it ends up obliterating the space, the free space within the lung, it's called consolidation, right? So this is the typical term used for lobar pneumonia. Lobar pneumonia is when all the alveoli are predominantly getting involved. There's a lot of exudates that is coming out of the alveoli, and that will end up leading to solidification of the lung. That's why the other term is called hepatization, right? So usually the lung is hollow and the liver is solid. So if the lung now gets filled with solid exudates, so to say solid exudates, then it's called hepatization. So we'll come across that in the next slide, red hepatization, gray hepatization. So lobar pneumonia is when mainly the alveolus is getting filled with exudates and leading to consolidation. Bronchopneumonia is when mainly it's the airways that are getting involved with the adjacent alveoli to an extent, but it's mainly the airways that are getting involved. Okay, so what happens is it's mainly the airways and then a little bit of the adjacent alveoli getting involved. So it gives an appearance of tree in bud. Okay, you'll come across this description of tree in bud. If you see it on a CT, if you do a CT and you try and look at the bronchopneumonia on a cross section, you'll notice that at the terminal part of the airways, there is going to be a little bit of a nodular opacity, and that gives that description of tree in bud appearance. That's bronchopneumonia. Okay, it's mainly the airways with a little bit of the adjacent alveoli being involved also. Interstitium also, it's never purely interstitium. It is an interstitial predominant inflammation. That's why it's called interstitial pneumonia. Okay, most often atypical pneumonias. You would have heard of this term, atypical pneumonias. Okay, are you guys answering in the chat? Maybe I'm not able to see. So I hope to keep this as an interactive session. Please interrupt me. Please correct me if I'm making any wrong statements. Please ask your doubts whenever you want to. If there are any chat comments, I will try and reply as and when there are. Okay, so atypical causes of pneumonia or atypical pneumonia is generally of the interstitial variety, and that is why it is atypical. That is why the patients don't end up having a lot of florid cough. The amount of inflammation is also limited, so they'll not have very high fever. They'll have low-grade fever. So the atypical variants or atypical pneumonias are also common cause of interstitial form of pneumonia. Okay, so the thing with lobar pneumonia is there are three things you should remember. Of course, the typical organism that causes lobar pneumonia is pneumococcus. Pneumococcus will produce lobar pneumonia, right? So that is the Streptococcus pneumonia, which is the most common cause of community acquired pneumonia. Most common cause of community acquired pneumonia is pneumococcus. That will produce a lobar pattern, an alveoli predominant inflammation. Along with that, you should remember bronchial breath sounds, and that to the tubular bronchial breath sounds. So what happens? The alveolus is filled with exudates. Only the airways are patent. Okay, to a certain extent, the airways are patent, whereas the alveoli are totally filled with exudates. So that is why when you hear the breath sounds, you're not getting the vesicular breath sounds of air moving in and out of the alveoli. Instead, you're getting to hear only the air moving in and out of the airways. So that is why you'll get a tubular bronchial breath sounds. That is a high-pitched bronchial breath sound. So remember, bronchial breath sounds suggest lobar pneumonia and not bronchopneumonia or interstitial pneumonia. Okay, why I stress on this is there was a question in your entrance exams 2 or 3 years ago where they had given a scenario of an HIV positive individual who had ended up developing tubular bronchial breath sounds or bronchial breath sounds. I suppose it was tubular bronchial breath sounds. Okay, and this was done particularly to distract you and to make you think HIV scenario was given just to make you think that it might be PCP. But no, PCP generally produces an interstitial predominant pneumonia. Okay, interstitial predominant pneumonia. Although we say it's interstitial predominant, there's a lot of alveolar inflammation in PCP. But basically, you don't get tubular bronchial breath sounds in PCP pneumonia. That much you should remember. If you get bronchial breath sounds in HIV or in any patient, you should think of lobar pneumonia. The most common cause should be attributed to pneumococcus. Okay, so that's why that point you should remember. Also remember something called air bronchograms, which you get on chest X-ray. So whenever you get consolidation, you expect that the person will have a bronchial breath sound on auscultation and air bronchogram. This is the same. So if suppose if this was the lung and a part of it was solidified, the alveoli are solidified, but only a little bit. That means only the airways passing through those segments of the lung where the alveoli are solidified, they would be visible as lucencies. Okay, so that those are called as air bronchograms. So whenever you notice air bronchogram on a chest X-ray, or you are able to appreciate a patient having bronchial breath sound, you should think of lobar pneumonia. The most common cause has to be a pneumococcal pneumonia. Okay, bronchopneumonia, of course, you can get a lot of crepitations on auscultation, and on X-ray you will see very nodular, multiple diffuse nodular opacities. Generally, bronchopneumonia is bilateral. Okay, bronchopneumonia is bilateral, whereas lobar pneumonia can be most often unilateral. Unilateral can be bilateral, but most often unilateral. Okay, interstitial again is bilateral. So all these viral pneumonias, or most viral pneumonias, produce interstitial pattern of pneumonia. Okay, but it's not exclusively in the interstitial, right? So now coming to community-acquired pneumonia per se, this is what both CVME stresses on, and most universities have classically asked questions based on what are the typical organisms which produce community-acquired pneumonia. These include, of course, the most common cause of community-acquired pneumonia is Streptococcus pneumoniae. And if you notice, like most of the names of these organisms also will end with either influenza or pneumonia. So H influenza B is the other cause, Moraxella catarrhalis. Okay, so catarrh, of course, means mainly the nasal catarrh, but then Moraxella catarrhalis is a very important organism, very important cause of community-acquired pneumonia in patients with COPD. Okay, so COPD patients can have exacerbations because of Moraxella catarrhalis infections. Klebsiella pneumonia and Staph aureus, these are notorious because they end up producing pneumonia. It is community acquired, but most often such patients will have some structural lung disease also, and it may target children also, and they produce something. Both Klebsiella and Staph aureus, they're notorious because they end up producing pneumatoceles. Are you guys able to, is the audio and video fine?
Yes, sir.
I hope it's fine, no? Okay, thank you. Thanks, Kishan. Yeah, so pneumatoceles, and these pneumatoceles can rupture, and these pneumatoceles themselves will appear like cavities on, if you're lucky, you can catch them on an X-ray. Otherwise, you might notice them on a CT scan. You will notice, especially in the upper lobe. So upper lobe cavitatory lesions resembling cavities, but they're called pneumatoceles, and these can rupture and produce hemoptysis. So that's why these organisms are important, especially in patients, in children also, in children as well as those with structural lung disease, including COPD, bronchiectasis and all. Okay, so these are the common organisms which produce typical pneumonia. Atypical pneumonia causes include atypical pneumonia. Anybody? Any causes for atypical pneumonia in the chat box? Anybody would like to point out? Chlamydia, very good. Chlamydia pneumoniae. So again, the surname, Chlamydia pneumoniae. That tells you what it mainly causes, chlamydia. Legionella, excellent. Legionella. Avantika has told Legionella. Excellent answer. So again, Legionella pneumophila. So Mycoplasma, Saranraj, very good. Mycoplasma. These are all common causes of atypical pneumonia, right? So sometimes you can also include viruses in them. These viruses, your respiratory syncytial virus, it could be even influenza virus. So viral pneumonia you can include in atypical pneumonia. So even Coxiella for that matter, Coxiella burnetii, pneumonias are also considered as atypical pneumonia. So there are certain features which are different from the usual typical pneumonia, typical lobar pneumonia. That's why the term atypical pneumonia is used. We'll come to that also. Okay, so how do you think these infections are being acquired? So what was previously thought, what was previously considered is that in patients who are developing community acquired pneumonia, the infection is only entering the lungs. The lung is totally sterile. That was what was previously being thought of, that the lung is a totally sterile organ. There's no commensals there, no microbiota within the lung at all. Okay, and how one gets pneumonia is because of accidental aspiration. So holds back all bacteria. Nothing goes into the lower respiratory tract. Stop. We have the air within the nose, and then the ciliated epithelium, right from all these, the cough reflex. Okay, all these are considered to be sterile. Now it's learned. Actually, now what is proposed is not that the lung is sterile. Even whatever amount of air you breathe, you could be breathing in and out pneumococcus. So as you take breath, the pneumococci bacteria are entering into your lung, but they're not able to establish any infection. So they're just coming out. Okay, so your lungs are not entirely sterile. You still have some bacteria within them, just that they're not able to establish. The environment within the lung is not conducive enough for them to establish an infection. But sometimes there is an event which occurs which causes damage to the respiratory epithelium within the lungs. So when there's a damage in the epithelia within the lung, that is when cytokines are released. And these cytokines, including interleukin 8, interleukin 6, tumor necrosis factor, these play a very important role. So TNF alpha, interleukin 6, interleukin 8, these play a very important role in producing a type of inflammatory response or an immune response, which allows certain bacteria to be able to go and settle and produce their infections. Okay, especially streptococcal. This is about community acquired. Okay, streptococcal pneumonia will be getting established because of an original insult. So that original insult could be a microaspiration. That original insult could be a preceding viral pneumonia. So a lot of times what may happen is a patient with measles or a patient with varicella. So in children, varicella is usually benign, it's harmless. But in adults, if an adult never had varicella during the childhood and then suddenly ends up acquiring varicella, it could lead to pneumonia. It could lead to a viral pneumonia. But that is soon followed by a superadded infection with streptococcus. So sometimes the other bacteria like staphylococcus or klebsiella. Okay, so an initial viral insult will damage the epithelium, and then these bacteria will go and end up settling there and producing their type of inflammation, their type of pneumonia. Okay, so it's not necessarily that a microaspiration or a macroaspiration is that predisposes to community acquired pneumonia. It's instead another event in which case there is a damage to the epithelium, which leads to a type of inflammation which propagates and ends up establishing pneumonia. Okay, so these are the causes of typical and atypical. We'll discuss about what the differences between them are later on. Okay, so what are the risk factors for pneumonia developing? So there are some extrinsic risk factors. I'm sorry, it's not come out properly. I think the words are missing. Anyway, we'll complete them. So what are the risk factors for a person to develop pneumonia? So there are some extrinsic risk factors and there are some intrinsic risk factors. So extrinsic risk factors include overcrowding, recent travel. Of course, you all know about COVID, right? So during COVID times, COVID is a pneumonia, right? So during COVID times, we used to always be asking this question to patients. Did you travel recently to a COVID hit area? This was in the beginning, at least. Eventually, COVID spread everywhere. But then overcrowding, especially in, let us say, old age homes. So old age homes, the big problem is they may be overcrowding, and each of those may be harboring different multi-drug resistant bacteria. So each of the residents, so old age home residents, may be having one form of or a different form of multi-drug resistant bacteria. So that may end up really spreading to each other. So there are very frequent outbreaks in such old age homes or nursing homes. Okay, and outbreaks even in general, like epidemics outbreaks like influenza, these could all water, which what can contaminated AC humidifier risk for which, yeah, which infection? Am I audible or is
Yes, sir. Now it's better.
I'm audible?
Yes, sir.
Now it's better. I'm sorry. I'm sorry. Okay, I hope now it's clear.
Okay.
Yeah. So what infection could be associated with the contaminated AC humidifier? If you guys can tell me. Contaminated AC humidifier. Legionella. Excellent. Acinetobacter. Okay, Acinetobacter. Malati has tried. Good attempt. Acinetobacter, more to do with hospital acquired, especially ventilator associated pneumonia rather than community acquired. Atypical mycobacterium. Okay, atypical mycobacterium could also, yes, that also can be a risk in contaminated AC humidifier, contaminated water. Okay, so correct. So what about exposure to birds, especially parrots? So exposure to birds, what pneumonia could that be a risk for? Which organism? Very good. Psittacosis. Psittacosis. Excellent. Excellent. Very good. And what about cat and cattle? Cat and cattle, which pneumonia? Actually, this organism can produce cat toxoplasmosis, okay, but toxoplasmosis is not a cause for pneumonia. Bovine TB, again, not a cause for pneumonia, community acquired pneumonia. Brucellosis, good attempt. Again, brucellosis, respiratory brucellosis is not a very common, it's mainly musculoskeletal or CNS that brucellosis affects. Okay, good attempt, everybody. It's Q fever. Okay, Coxiella burnetii. Coxiella burnetii, it's actually a zoonosis. Brucellosis is also zoonosis, no doubt. But Coxiella burnetii is a zoonosis which is acquired from exposure to cat and goats, okay, cattle exposure. And that can also produce infective endocarditis. So what you should remember is it will produce atypical pneumonia, Coxiella burnetii, but it will also produce infective endocarditis. And very importantly, I suppose we'll discuss about infective endocarditis in a different class. Okay, so what are the intrinsic factors which will be predisposing an individual to risks for getting a pneumonia? These include advanced age. So what is the age cutoff beyond which you feel the person will be at higher risk for pneumonia? The age beyond what? Very good, 65. Excellent. So please do remember that age, because age beyond 65 years is a higher risk for pneumonia. That is why it is considered importantly in curb 65 scoring. Whenever pneumococcal vaccines are indicated or influenza vaccines are indicated, it's mainly for those age 65 years and above. So it's a very important age cutoff. Okay, apart from age, The other intrinsic risk factors for developing pneumonia would be any risk for aspiration. Aspiration risks could be either neurological risks, like for example, those who have bulbar palsies, who have difficulty pneumonia. It could be that is a neurological cause or neurogenic dysphagia. There could be a structural dysphagia also, or mechanical dysphagia also. So for example, somebody who has achalasia cardia or severe GERD, this is also a risk for pneumonia. Or, other than this, you could also have intrinsic risks in the form of immunosuppression. So conditions which produce immunosuppression would be like HIV, advanced HIV, that means CD4 levels are very low, or uncontrolled diabetes mellitus, or malnutrition. So all these are associated with reduced cell-mediated immunity. Any condition which reduced cell-mediated immunity, it could be steroid intake, it could be chemotherapy for malignancy treatment. So any of these which cell-mediated immunity could predispose to pneumonia. Okay, so these are the intrinsic risk factors for pneumonia. This apart from structural lung diseases. So certain conditions like COPD, like bronchiectasis, where you know that the patient's lung are not in a condition to be able to defend themselves. So in a patient with chronic bronchitis, there's always excessive amount of exudates within the bronchi, which can easily attract infection. So that is why they're always going to be prone to develop recurrent exacerbations of COPD. Whereas in bronchiectasis, there is a necrotizing inflammation. In fact, patients with bronchiectasis are almost throughout the year, they're going to have a continuous undercurrent of infection going on. So that is what leads to the bronchiectasis in the first place. Bronchiectasis, ectasia means dilatation. So bronchi get ectatic, and that is because of recurrent infection, necrotizing infections. Okay, so that is again another intrinsic risk factor for developing pneumonia. Right. So this is the typical, or this is the classic description of the pathological stages of pneumonia. These are mainly for lobar pneumonia. So lobar pneumonia generally goes in this order, where there's a stage of congestion, followed by red hepatization, gray hepatization, and then finally resolution. Right. This is for a typical lobar pneumonia, where it progresses like this. So congestion because of hyperemia, because there's inflammation. Right. So whenever there's inflammation, there's going to be rubor and calor. So there needs to be an increased blood flow towards that inflamed part. So that's what leads to congestion. Finally, there's going to be exudation. The capillaries are going to allow all the major proteins, the large molecular weight proteins, to escape, and that produces the exudates. So this exudation along with RBCs, so that's why it produces stage of red hepatization, then followed by RBCs start to get lysed, and that leaves behind only the exudates, which is a stage of gray hepatization, then finally resolution, right? So during this hepatization stage, you will get tubular breath sounds, or rather bronchial breath sounds. Okay, bronchial breath sounds, tubular bronchial breath sounds. During resolution and congestion, you will get crepitations. Okay, crepitations. This is an auscultation I'm saying. So when a patient has lobar pneumonia, if you can see the difference in the stages based on the auscultation findings that you can get. This is typical lobar pneumonia. Atypical does not go through these stages, these classical stages. Of course, you will still get fine crepitations in them when you're auscultating for them. That's the difference between atypical and typical. One of the examination findings, you don't get the typical bronchial breath sounds in atypical pneumonia. Rather, you get it in lobar pneumonia or typical pneumonia. Okay, so that is in terms of pathology. Now, coming to clinical features, I already briefly discussed about how it happens, right? So it's not always a micro aspiration. It's some form of epithelial damage or some reason why the cell-mediated immunity has been diminished, which allows the bacteria to get an upper hand. The bacteria are always there in the lung. If a person is walking through the hospital, he'll be breathing in air which has Acinetobacter, like one of you said. Why creps heard in resolution? That's what. So there's still exudates, but they're not as solid as during the hepatization stage. So there are still some amount of crepitations some amount of exudates within the alveoli yet to get fully resolved. Okay, till the entire inflammation has resolved and totally resolved, till then there will be no amount of, in terms of audio is
Yes,
breaking.
sir. There is some problem with audio.
Okay, is it better? Is it continuous right now when I'm
Now it's
speaking?
okay, sir.
Then I'm so sorry for the audio. I'll have to fix that. Okay, so what I was saying was, when a person, let us say the person's infection has totally, suppose the patient had a course like this. Okay, it started with fever and then cough, and the amount of inflammation kept increasing, and then finally the body's immunity started taking the upper hand and the person started to improve. Okay, when even after the during the improvement, what happens is the first to break will be, or the first to stop will be the fever. Fever resolves the fastest. So if you're treating a patient with pneumonia, the patient's fever has to come down, uh, to show, to be able to indicate that yes, the person is responding to your treatment. Okay, along with leukocytosis. So leukocytosis and fever, these are the best indicators to see if the patient is responding to your treatment. So when you're treating a patient with pneumonia, watch out for these two, because these will indicate the fastest indicators for recovery or resolution. Then will your crepitations and your lung findings improve. Okay, so the crepitations will get delayed even when the person is improved, the infection has come down, the person is on the road to recovery, the crepitations will persist. And that's because not all the exudates will suddenly vanish. Take some time for all those exudates to get resolved. Until then, the creps will still be appreciable. And then finally, the X-ray features. So the last to get better would be the X-ray. So X-ray is not a good indicator to check if the better or not, because those exudates, so the person's infection is gone, the person's afebrile patch, or the exudates or infiltrates. Okay, so repetitions. Okay, now what are the clinical features? Still breaking? Still voice is breaking? Okay.
It's okay, sir. We can continue. I mean, the middle 1 2 words gets broken, then that's okay, sir.
Okay, I'll try and repeat.
Or else you can switch off your video, sir, so that you get a better bandwidth for your internet.
Okay, so what are the clinical features for pneumonia? Fever. Okay, right. So we'll continue. We'll discuss the clinical features next. So if a patient has pneumonia, obviously in a typical community acquired pneumonia, you expect the person to develop fever. Okay, and in a typical lobar pneumonia, you get continuous fever. So you all know the patterns of fever, and fever pattern, when we say continuous, we mean that the person has temperatures, the body temperature not touching baseline. Okay, so if this was the baseline, the body temperature would never touch the baseline, and yet the fluctuations would be less than 1 degree. Okay, so in a 24-hour period, within 24 hours, the temperature never touches baseline, does not touch baseline. That means it's always elevated throughout the 24 hours, and the fluctuation within the day, fluctuation is, or the variation is less than 1 degree. Okay, less than 1 degree centigrade. This is continuous fever. Okay, and the typical example for continuous fever is lobar pneumonia or streptococcal pneumonia. The other examples include urinary tract infection and meningitis. Okay, so all these syndromes, like, so pneumonia is a syndrome, meningitis is a syndrome, urinary tract infection is a syndrome. So these infectious syndromes, they typically produce continuous fever. This is for lobar pneumonia or typical pneumonia. Atypical pneumonia will be atypical. So the fever will be low grade. Okay, the amount of inflammation is not as much as what happens within the alveoli. That's why the amount of fever that occurs in patients with atypical pneumonia is also not that bad, not high, not as high. So high grade fever, continuous fever, this is something that is associated with lobar and typical pneumonia. Atypical pneumonia is a low grade fever. Okay, cough. Cough, obviously you expect a patient with pneumonia to have cough, and that is what makes you suspect. So if a patient presents to you with fever and cough, one of the suspicious, you will obviously think of a respiratory infection, whether it's an upper respiratory or a lower respiratory, you have to decide next. But if a patient with pneumonia has presented to you, cough will be invariably present. Now, is the cough dry, or is the patient having sputum when the patient is coughing? Dry cough would be something, a pneumonia that is associated with atypical pattern. So atypical pneumonia has dry cough. That is because predominant inflammation within the interstitium, there's not much of alveolar exudates. So when the person coughs, he's not bringing out much. That's why a dry cough is more suggestive of an atypical pneumonia. But another reason why a person, even though patient has lobar pneumonia, the patient's cough may still be dry. Why should a lobar pneumonia patient have dry cough? If the patient is dehydrated. Now, what we need to realize is dehydration is very common among patients of lobar pneumonia. That is because they will be tachypnic, and as they're tachypnic, they will be breathing through their mouth also. So they're losing a lot of water vapor in trying to breathe through the mouth to keep up with the oxygen demands. Now, because there's consolidation, they're having to breathe little harder. In order to do that, they need to breathe through their mouth. They lose a lot of water vapor. So dehydration is common among patients who are tachypnic, breathing through their mouth, even with lobar pneumonia. So when they are dehydrated, the exudates also end up becoming little less liquidy, more solid. Okay, so that may also not come out. So that is why they'll have dry cough. And that is why the dehydration is so important. Again, in curve 65, dehydration is given an important role, being indicated by the blood urea. So in curve 65, why are we considering blood urea? Because that indicates the degree of dehydration. There's also a little bit of dehydration because of third space loss. The exudates themselves are a form of loss of water into the alveoli. But again, mouth breathing is another indicator. And the fever. If the fever is very high grade fever that occurs in lobar pneumonia, that also contributes to dehydration. So multiple reasons why the person is dehydrated. And that is why blood urea, the urea level is considered as an indicator of severity of pneumonia in curve 65. Okay, so what typically happens is when the patient presents to you, you may not get too many lung findings, too many, or the patient may not have dry, productive cough, but you give them IV fluids to try and restore their hydration, and their cough suddenly becomes productive again. Okay, so that's because now the dehydration is corrected. Otherwise, the patient may be producing sputum, and in which case you may get some clues with regards to what the causative organism may be looking at their sputum. So rusty sputum, any idea, guys? This is very typical question. That is, these are typical questions asked by old-time examiners regarding which cause of pneumonia produces rusty sputum, which pneumonia produces very good. Streptococcus pneumonia, excellent. Excellent. Streptococcus pneumonia produces rusty sputum. Rusty sputum, that's because there is some amount, there are some RBCs that are present within these exudates. During the red hepatization, those RBCs are being brought out. So that's why the rusty sputum. Okay, and these streptococci, they also have a lancet shape, no? So maybe that's how you can remember. The lancet is causing a little bit of bleeding. So rusty sputum, RBC is coming out in the sputum. That's rusty sputum. RBCs also come out in currant jelly sputum. But the typical description of currant jelly sputum is associated with which microorganism? Any idea? Currant jelly sputum? Klebsiella. Excellent. Excellent, Avantika, Saranraj. Klebsiella does produce, okay, this is pneumococcus, and Klebsiella produces currant jelly. Excellent. Klebsiella pneumonia. Next, green sputum, obviously. Pseudomonas, excellent. Pseudomonas. So the green pigment that is produced by the pseudomonas will produce a green sputum. Excellent answer, Vashishta. Actually, these pseudomonas, they are by themselves, they will not attack a normal lung, but very frequently they will attack a diseased lung like COPD patients, like bronchiectasis, cystic fibrosis. That is when you get pseudomonas producing pneumonia. Excellent, Sushmita. So pseudomonas will end up leading to greenish sputum. Black sputum, any idea, guys? Black sputum, I'm talking about pneumonia. I know excellent answer. Even before I could aspergillus. You guys are very nice, very nice. Sinchana, Sushmita, all of you, very good answer. Because a lot of times when I ask this to my students, the answer I get is co-workers pneumonia. Yes, co-workers pneumonia also produces black sputum, but that's not an actual infection that is producing pneumonia, right? That is also a non-infectious pneumonia. But among the infections, Aspergillus, yes, that is the answer I usually expect. Aspergillus does produce Aspergillus fumigatus, right? That is more common in producing invasive aspergillosis that can lead to black sputum. Okay, and that is again something that is common in some certain parts of India, especially the Madhya Pradesh belt. Okay, so Madhya Pradesh belt that typically has Aspergillus producing pneumonia. Okay, again, certain words are missing from the slide. I'll complete them myself. Uh, Breathlessness. So this is how it is. Typically, as the consolidation progresses, it will start with cough. And as the consolidation progresses, if enough volume of the lung has now gotten involved, become hepatized, then the person will lose surface area, right? So basically, alveoli are meant to allow oxygen to enter into the lungs. So once that sufficient amount of surface area is lost, they'll start developing deficiency of oxygen, that's hypoxia, which will manifest as breathlessness. So the patient will complain of breathlessness. Again, this will reflect in the respiratory rate. So as the respiratory rate goes up, the curve 65 also goes up, right? So any patient who's having severe pneumonia will end up having breathlessness. Okay, bronchopneumonia patients will develop breathlessness earlier. Okay, because bilateral lung involvement and sufficient amount of airways getting involved, that time they'll develop breathlessness quite early. Interstitial pneumonia also can end up having pneumonia, breathlessness. So basically, if there is a loss of the alveolar exchange, that means the pulmonary membrane, if the pulmonary membrane is damaged, then there's going to be loss of gas exchange at the alveolar level, and that's why it lead to breathlessness. Okay, what are the other features that we can expect in pneumonia in terms of history? So can you get hemoptysis? Yes, you can. I told you already. Pneumatoceles typically associated with two infections. These are two infections which produce pneumatoceles, thereby leading to hemoptysis. Of course, you can say tuberculosis. I hope my audio is okay. Tuberculosis also leads to hemoptysis. That is also technically a pneumonia, but we will not consider it in today's class, community acquired pneumonia.
Staphylococcus Klebsiella.
Very good. Excellent. Staphylococcus and Klebsiella. Typically, upper lobe pneumatoceles rupture produce hemoptysis. Okay. Sometimes they will end up having confusion. Okay. And that's why the curve 65 starts with C. So confusion. Okay. Especially among elderly patients. Elderly patients, they may not manifest with fever. The problem with elderly patients is already their body water levels are low. So they will not have productive cough. They will have dehydration. Their respiratory capacity will also be compromised. So age-related reduction in respiratory parameters and chest movements, all these will be less. Okay. So, and that is what is going to make them prone to develop pneumonia in the first place. So age above 65, why is it going to be leading to pneumonia? Because their respiratory capacities come down, the body water levels come down. So all these are going to predispose to pneumonia. But if they're having an infection like a pneumonia, they may not manifest as having a fever. Okay, so instead they will end up having confusion or altered sensorium. So if a patient who is elderly suddenly developed altered sensorium, one of the differential has to be an infection. The infection could be a pneumonia, could be a urinary tract infection, okay, and not necessarily meningitis. So just because a patient has fever, or rather just because an elderly patient has an infection which has led to altered sensorium, it need not be localized to the meninges or the brain. It could just be a pneumonia or a urinary tract infection which has precipitated confusion. Okay, so confusion could be a manifestation. One more thing you should keep in mind is this kind of altered sensorium in pneumonia could be seen in atypical pneumonia, especially Legionnaire's disease. Legionella pneumonia can lead to CNS manifestations in the form of encephalopathy. Additionally, Legionella can also lead to hyponatremia. So that also leads to SIADH, leads to encephalopathy. Okay, Legionella, as part of its extrapulmonary manifestation, it can lead to encephalopathy and confusion, but it can also reduce the sodium levels, thereby that will also lead to encephalopathy. Okay, so these are additional manifestations that you can get. You can also get wheezing. Okay, it's not that only patients with asthma or COPD should have wheezing. Wheezing can also occur with pneumonias, especially bronchopneumonia. Bronchopneumonia patients can end up having wheezing. So these are the symptoms that one can expect in patients with pneumonia. Okay, right, from fever, cough, different types of sputum, breathlessness, hemoptysis, confusion, and wheezing. These are symptoms. What about the signs? Okay, and hold on. Just before we go on to signs, certain non-respiratory complaints. I already told you the neurological manifestation. Neurological manifestation, thanks to especially Legionella pneumonia. Loose stools, very often even in Legionnaire's disease, also in H1N1. So H1N1 patients typically also have loose stools and abdominal complaints. Okay, abdominal pain could also be seen in Legionella. Legionella can present with abdominal and CNS manifestations. They can also have hyponatremia also, Legionella, as I already said. Myalgia, so diffuse myalgia could be one of the manifestations. Hematological, so I know there are some PGs who had signed up. If I could ask you guys, the PGs who are in the session, which pneumonia will lead to HUS? Any idea? Which pneumonia will lead to HUS? Hemolytic uremic syndrome. Okay, that is one question. And which pneumonia will lead to autoimmune hemolytic anemia, especially the IgM variety? That means the cold agglutinin disease, the IgM mediated autoimmune hemolytic anemia. If the PGs could answer, otherwise, these are both tough questions. This one especially is a tough question because it's not very well known. Very good. Aditya has answered that autoimmune hemolytic anemia, that is the cold agglutinin disease, can occur in mycoplasma infections. So the patient could have, it could all begin with a dry cough, mild fever, and then you hear some crepitations in the lung, and then you notice that the patient is pale, and then you check for direct Coombs test, and the direct Coombs test may be positive. That could all indicate mycoplasma. Mycoplasma does lead to IgM. So M for mycoplasma, and M is the antibody type of antibody that is produced, that is induced by mycoplasma to produce cold agglutinin disease. Okay, HUS, not an easy answer. Oh, somebody had answered. Netra, very good. Netra and Aditya both have answered. Very good. It is Streptococcus pneumonia. So Streptococcus pneumonia can produce HUS. Okay, because it ends up producing something called neuraminidase. Now, when you talk about H1N1, this N actually stands for neuraminidase. So we don't expect Streptococcus to be producing it. We expect the viral influenza to produce it. But sometimes neuraminidase is produced by the Streptococcus pneumoniae, and that can predispose to HUS also. So that is another rare manifestation of extra pulmonary manifestation of pneumonia. Okay, so nice, you guys answered that. These are the non-respiratory complaints. Otherwise, examination, usual drill. How does pneumonia cause encephalopathy? Is it due to spread of organism by bloodstream? Very good question, Arjun. Very good. Actually, one of the complications of pneumonia is this kind of a bloodstream spread leading to meningitis, no doubt. Because if you see what are the common causes of meningitis, that also includes Streptococcus pneumonia. The Streptococcus pneumonia is the most common cause of meningitis. How does it get there? Unlike the lung, the brain definitely, the CSF definitely is a sterile area. There's no bacteria there at all. No scope for bacteria to be normally present within the brain. The lungs, yes, because you breathe in air. But the focus most often is in the lung. So from the lung, it ends up spreading into the meninges to produce meningitis. That is true. While that is true for pneumococcal meningitis, that is true for tubercular meningitis. Okay, but that is not the reason why encephalopathy is produced in most patients with pneumonia. So in pneumonia, what happens is it depends on a person's cerebral blood flow reserve. So if in order to provide blood to the brain, so let me represent the heart here. Now it has to supply blood to the brain, it has to supply blood to the lungs. I'll represent lung like this. Okay. Now, if it is normally supplying blood to both areas, things are going fine, no worries. Now, what happens either with aging or with atherosclerosis, or for some reason, the blood vessels are stenosed in the brain. Okay, so with aging, this is invariably going to happen. There is going to be some amount of stenosis of cerebral blood vessels. So yet the person under normal circumstances, the brain is not affected. It's getting its minimum quota somehow is being met. Blood supply is being met, so brain is working fine. Okay, and lungs are doing their part. But now if suddenly there's a lung infection and there's a pneumonia, what is going to happen? The stage of congestion, there's going to be an increased demand. Any infection will demand more blood towards it. So as a result, there is going to be a sort of diversion of blood or stealing of blood, coronary steal, you say, no? By that only, there's some amount of extra blood that is going to be pumped in towards the lung. That may end up compromising. Already there is stenosed blood vessels in the brain. So that may end up drawing away blood that was necessary to maintain the minimum amount of blood supply towards the brain. If it's not getting that, then they may manifest with confusion. Then they may manifest with altered sensorium. Okay, so it depends on if the patient had atherosclerosis or other or advanced age, any reason why the person's blood flow towards the brain was even before the pneumonia, if it was compromised. Okay, otherwise a younger person may not experience confusion, may only experience respiratory symptoms. Okay, and hyponatremia, especially in Legionella disease, can also end up contributing to the altered sensorium. And finally, hypoxia. So as the oxygen level comes down, you all know that the person as oxygen as hypoxia manifests, one of the manifestations will be delirium. Okay, so as oxygen levels come down, the person may manifest with delirium also. Okay, so these are all combined reasons why there may be encephalopathy features in patients with pneumonia. Okay, but nice question, Arjun. Yes. So, what are the examination findings on in patient with pneumonia? Obviously, if the person has to make up for the loss of alveolar or respiratory membrane surface area, he has to try and breathe harder. So there is going to be tachypnea. Respiratory rate increases. That's why curve 65 counts it, and accessory muscles of respiration will be put into use. Okay, so the ala nasi, the scaleni, the sternocleidomastoid, the pectoral muscles, all these, the internal intercostal muscles, abdominal muscles, all these could be brought into play to try and maintain the respiratory rate, right? And along with that, you'll notice that there is diminished chest movements. So diminished chest movements in the particular area. So if a patient has lobar pneumonia, that particular area or segments of the lung would be affected. There'll be diminished chest movements. Okay, increased tactile fremitus and vocal resonance. That's because of consolidation. Solid exudates will conduct the sound better than air, right? That's physics. So likewise, if there are solid exudates within the lung, I'm saying, so it has to be within the lung. Outside the lung, pleural effusion and all, it will cause diminished vocal fremitus, tactile fremitus, and vocal resonance. But within the lung, if there is solidification, the sound gets conducted better. So you can appreciate an increased vocal resonance. Agophony is a nasal quality. So when you ask the person to say E, it will come out. You guys know this is vocal resonance, right? So the person is, you have the stethoscope, your stethoscope chest piece on the chest wall, patient's chest wall, and the person is instructed to say E. Okay, when they try and say E, and if there is a consolidated area within the lung, you keep the chest piece over that and try and hear that E, it'll come out as a. Okay, it'll be like a nasal quality, bleating of a goat. That's how it's described. So egophony is when there is a nasal quality imparted to a person's vocal resonance. Okay, so it's a change in quality. When there's a change in quantity, it's called bronchophony. Okay, please be familiar with these terms. These are important for clinics. Okay, I'm sorry, bronchophony. Bronchophony is when the vocal resonance is increased. It's a quantitative change. Quantitative change with an increased vocal resonance is called bronchophony. Quality change, that means change from E to A as a result of bronchopneumonia, or rather lobar pneumonia, it's called agophony. Okay, agophony can also be found in at the level of pleural effusion. The level of pleural effusion can also get agophony. Okay, these are examination findings that you can get. Woody dullness on percussion, that you all will be taught in your clinics. So stony dullness is pleural effusion, woody dullness is lobar pneumonia or consolidation. Tubular bronchial breath sounds, these are high pitched sounds. You all know that when you're comparing if you're trying to auscultate the audible inspiratory part, no, the audible inspiratory part normally should be longer than the audible expiratory part when you're trying to listen to breath sounds, vesicular breath sounds. That's how it's supposed to be. But in tubular bronchial breathing, what happens is it's high pitched. The audible inspiratory and the audible expiratory part will be nearly the same. Sometimes the audible expiratory part may be longer than the audible inspiratory part. Okay, and there'll be a gap. So these are the two differences between bronchial breath sounds and vesicular breath sounds. So bronchial, there'll be a gap between the inspiratory and expiratory phases, the audible inspiratory and audible expiratory phases, and the length or the duration of the audible expiratory phase is prolonged. Whereas in vesicular breath sounds, the inspiratory phase is vesicular breath sound inspiratory phase is longer than the expiratory phase, and there's no gap between the two. Okay, so this is about the auscultation finding. Crepitations and wheeze both you can find. So rhonchi, okay, rhonchi, wheeze. Sometimes some examiners say that wheeze is what you hear, and rather wheeze is what the patient can tell you that they're experiencing, whereas rhonchi is what you hear on auscultation. But it's all very technical. Both are the same. Okay, it's produced because of bronchoconstriction. Basically, patient is having bronchoconstriction. Some sound is being produced. You can call it wheeze. You can call it rhonchi. Maybe certain old-time examiners may expect that you say wheeze is a symptom, rhonchi is an examination finding. Okay, so coming to complications of pneumonia, what could it lead to? It will lead to respiratory failure. It can lead to ARDS. Okay, so basically what happens initially, there's going to be a drop in PaO2. So whenever there's a drop in PaO2, the partial pressure of arterial oxygen, that is going to be known as type 1 or type 2 respiratory failure, basically. Respiratory failure. So drop in PaO2 by itself is respiratory failure. Most often pneumonia, because it's an acute process and we expect that the underlying respiratory mechanisms are still intact, they should have type 1 respiratory failure. So the most common type of respiratory failure in pneumonia is type 1 respiratory failure, wherein the PaO2 is reduced, the PaCO2 is either normal or it is reduced. Okay, so normal or reduced PaCO2 along with low PaO2 is type 1 respiratory failure. Type 2 respiratory failure, you should all know, is PaO2 is again low, obviously, but PaCO2 is high. So basically, in patients who have a ventilation issue, whose respiratory muscles are not able to keep up with the demand, the oxygen is reduced, yet the respiratory muscles are not able to breathe fast enough. Okay, in such patients, they will have type 2 respiratory failure. So pneumonia being an acute process, most often we don't expect them to have type 2, we expect them to have type 1. But that being said, sometimes the risk factor, it depends on the risk factor. No? Suppose a patient with GB syndrome, a GB syndrome patient, because they have respiratory muscle paralysis, they are still prone for developing pneumonia. So if a patient of GB syndrome with respiratory muscle paralysis develops pneumonia, they will have type 2 respiratory failure because their muscles are not able to breathe fast enough, their carbon dioxide levels rise. So this is type 2 respiratory failure. But that's an exception to the rule. The most common type of respiratory failure is type 1 respiratory failure in pneumonia. Now, if along with this, the PaO2 has come down, along with that, the ratio of PaO2 to FiO2 comes down less than 300. This is called as ARDS. Okay, so when the when PaO2 is low, it's called respiratory failure. If the PaO2 is low along with normal or low PaCO2, it's type 1 respiratory failure. But if the ratio of PaO2 to FiO2 comes down below 300, it's called ARDS. By definition, it's called ARDS. Okay, so that's another. In fact, pneumonia is one of the most common causes of ARDS overall. Overall ARDS, the most common cause is pneumonia and sepsis. These are the two most common causes of ARDS. Okay. Beyond that, lung abscess. Now, pneumonia is just an inflammation, but if this inflammation ends up getting organized, then it's called an abscess, lung abscess. Abscess where there is going to be a lot of necrotic tissue gathering in an anaerobic environment. So when there's necrosis, when all the dead cells along with the exudates, they get mixed, that leads to, now, normally there is some blood flowing towards the lung, right? So if this is the lung, and let us say even a small area of it is getting inflamed, it's consolidated, no problem. So there's still blood flowing towards this, it's not become avascular. Now, instead, it ends up becoming filled with pus because the necrotic tissue has now mixed with the exudates. And this necrosis is an area where the blood flow is not happening. So blood flow is not happening, and therefore within this pus, it is going to be avascular, which means anaerobic organisms can end up settling and proliferating. So anaerobes can gain access to this, and they can end up proliferating. So abscess formation will invite anaerobes to come and proliferate, because there's no blood coming, there's no oxygen being brought by the blood vessel, so anaerobes can proliferate. So lung abscess is a situation where inflammation has ended up leading into necrosis and collection of pus. Okay, very often lung abscess can occur in staph pneumonia, and as well as Klebsiella. Okay, Klebsiella, Staphylococcus. Please remember pneumatoceles, hemoptysis, and lung abscess also. Lung abscess is a very common. Oh, I'm sorry, Avantika had asked what is FiO2. FiO2 is the fraction of inspired oxygen. Okay, FiO2 means, I'm sorry, fraction of inspired oxygen. So that means when you're breathing in air, no, so we know that air, it's composed of 21% of oxygen, right? So it's like 70+% of nitrogen, and then 21% of oxygen, and then the rest is made up of carbon dioxide and other gases, right? So 21% would be the, if you're breathing in air, 21% would be the FiO2, the fraction of inspired oxygen. So likewise, suppose a patient, you give them nasal prong, you give them oxygen via nasal prongs. So in that case, you may be giving them, if you're giving them, let's say, an oxygen at 3 liters nasal prongs, you might be getting, so you might, if you're giving them 3 liters oxygen via nasal prongs, you might be giving them FiO2 of somewhere around 28%, right? So that becomes the FiO2. The fraction of the inspired oxygen is called FiO2. The ratio between the partial, the partial pressure of arterial oxygen and the FiO2, if it is less than 300, this is defined as ARDS. Okay, so if you take it normally PaO2 should be somewhere above 80. Okay, so let us take it as 80 itself. And normal, like we said, FiO2 in air, atmospheric air, is 21%. So normally this ratio should, into 100, this is of course. So this ratio should not be less than 400, right? So it should be somewhere around 400, if not above that. But if this ratio becomes below 300, then this becomes one of the criteria to say patient has ARDS. Okay, Sinchana has asked, can you repeat the organism part for lung abscess? Okay, so lung abscess. So as I was saying, no, initially what was taught is pneumonias are occurring because of aspiration, and therefore all aspiration pneumonia is a separate term. In fact, that's what is mentioned in CBME also. Aspiration pneumonia was thought to be because of anaerobes. So which are the organisms that are entering into the lung when a person is aspirating? Either the oral contents are going in or the gastric contents are going in, correct? So if a person is aspirating, as it is, either the oropharyngeal contents or the gastric contents are going in. Now, anaerobes are known to be present within the oral cavity, especially within the teeth. So there are certain anaerobic pockets that are present within the teeth, where gram-positive anaerobes like peptostreptococci. So these peptostreptococci, these are normally present within the teeth and in the dentition. Okay, there are some anaerobic environments there. But if these are aspirated, they may end up leading to aspiration pneumonia. This was what was thought. And therefore, any aspiration pneumonia earlier was being treated with anaerobic coverage. So any patient who has presented with obvious aspiration, macro aspiration, they need to be treated with anaerobic coverage, is what was thought earlier. Now it is known that even in aspiration pneumonia, it's not highly likely that anaerobes are going to contribute to the infection, because lungs are generally filled with oxygen, and oxygen is not going to allow anaerobes to proliferate easily. So unless there is an anaerobic environment that is established within the lungs, or the dentition is very, very bad, if the oral dentition is highly unhygienic, very poor dental hygiene, then the chance of anaerobes producing pneumonia is high. So either the patient's dentition should be very bad, or they should have an environment like a lung abscess where there is a collection of necrotic tissue within the exudates, therefore becoming avascular. So when there is a lot of pus, it's going to destroy everything. So as there is, when the pus starts accumulating, it will grow, right? It will only expand. It will eat away into the rest of the tissue. In fact, it's called pulmonary gangrene. When the abscess keeps eating away at the surrounding tissue and keeps expanding, it will end up destroying the surrounding lung tissue. So all the when the necrosis is spreading, the blood supply to those parts is lost. It's dead. The tissue is dead. So blood is not going to be reaching towards it. That allows, if the blood is not reaching towards it, then oxygen delivery is hampered. Therefore, this allows for an anaerobic environment to be established. So that is when anaerobic spores, like for example, peptostreptococcal spores, these can come and proliferate. So you don't start treatment for aspiration pneumonia with anaerobic coverage unless the person has lung abscess, or if the person has a very poor dental hygiene, or if the patient has bronchiectasis. Bronchiectasis is also a suppurative lung disease. So you guys may be asked this question by your clinics examiners. What are suppurative lung diseases? You all know suppuration means lung abscess. So suppurative lung disease is, examples are, or the types are, one is lung abscess. Abscess. Then bronchiectasis and empyema. Technically, empyema is not within the lung. It's in the pleura. It's pus in the pleura. Empyema. Okay, so these are the suppurative lung diseases. If the person has a risk for this suppuration, then anaerobic coverage is required. Otherwise, not essential for all aspiration pneumonia. That is the current change in thought, current change in approach towards aspiration pneumonia. Okay. I hope that was that's clarified Sinchana's doubt. Okay, and then it can lead to pleural involvement leading to pneumonic pleural effusion, which can get complicated, again, can end up developing into an empyema. That's what I was saying. So if there is a pus collection that occurs in the pleura, then it is empyema. Okay, again, anaerobic involvement there. So anaerobes are everywhere, just that they're not being allowed to grow because there's oxygen also everywhere. If they find a suitable environment, like in the teeth, where there are cavities and there are pockets where the oxygen doesn't end up reaching, there they can establish their infection. Okay, and bronchiectasis. Overall, later on, over the course of time, bronchiectasis can occur. Okay, it's not an acute complication. Again, it's missing, but non-pulmonary complications. So non-pulmonary complications of, I'll write it here, non-pulmonary complications of pneumonia, non-pulmonary complications. These will include sepsis. Now, one of the most common causes of sepsis is the lung. If there is a patient who has developed sepsis, one of the foci for that sepsis may be in the lung. So sepsis is one of the complications. Again, Legionella can produce hyponatremia. That is another complication. And then, of course, seeding of the infection. The infection from the lung may be it might end up getting seeded, or rather there's a seeding of the infection in the CNS leading to meningitis, in the heart leading to infective endocarditis. Okay, it might end up producing infections in different parts of the body. It could be even spreading into the liver. Okay, producing pyogenic liver abscess, pyogenic liver abscess in the heart leading to endocarditis, and in the brain leading to meningitis, meningoencephalitis. So this kind of seeding is also, and of course we already discussed about HUS and autoimmune hemolytic anemia. That is specifically to Mycoplasma and Streptococcus pneumoniae. These are the extrapulmonary or non-pulmonary manifestations of pneumonia. Okay. So these are the complications associated with pneumonia. Moving on to investigations. Okay, so what do you want to see in investigations for patients with pneumonia? Very, very helpful clue is leukocytosis. I told you already, leukocytosis helps to predict whether the patient is responding to the antibiotic adequately or not, appropriately or not. So patient will develop leukocytosis, especially when it is a typical pneumonia. Lobar pneumonia, you expect patient will have elevated WBC count. Leukopenia may be present if the patient has a viral pneumonia. viral pneumonia, especially H1N1. So what happens is H1N1, generally it's a virus. So the virus will elicit expression of interferon gamma. And interferon gamma will be antiviral. It will want to eradicate the virus, but it also suppresses the bone marrow. So bone marrow suppression will occur. As a result of that, you will get thrombocytopenia and leukopenia. Okay, you won't get anemia because this is an acute process. You know, RBCs have a lifespan of 120 days. So you can't expect anemia just by suppressing the marrow for a few days. But that's what happens in H1N1. For a few days, the interferon gamma, which is trying to eliminate the H1N1, will also suppress the bone marrow. And it's not just H1N1, any viral pneumonia for that matter. Any virus will be countered by interferon gamma. In fact, interferon gamma was used for treatment of hepatitis C previously. Previously, we used to use interferon gamma for or interferons for treatment of hepatitis C, even hepatitis B. That's because they have antiviral properties. But along with that antiviral property, it will suppress the bone marrow. That is why you will get leukopenia and thrombocytopenia also. These may be present. In fact, leukopenia has a poor prognosis. It has a worse prognosis than leukocytosis in patients of pneumonia. Okay, severity, it indicates greater severity. So severity of pneumonia is indicated more by leukopenia than by leukocytosis. That is because of the bone marrow suppression that happens. Okay, thrombocytopenia may also be present. Blood urea nitrogen, the only reason you're checking for blood urea nitrogen in patients of pneumonia is not because you're worried about the kidney, it's because you want to calculate the CURB65 score, and that is an important parameter used in calculation of CURB65, which will indicate whether the person needs to be, how the patient needs to be managed, whether the person needs to be admitted or not. Okay, so these are just the general investigation that you would do, right? What about an X-ray? Obviously, any patient with pneumonia, supposing the patients come to you and you're auscultating and you find there are certain findings like bronchial breath sounds or crepitations, you have to ask the patient to get an X-ray. Even if the CURB65 score is 0, you need to ask the patient to get an X-ray. Okay, so please don't miss doing an X-ray for a patient who has a suspected pneumonia, even if the patient is not getting admitted. So if it's a lobar pneumonia, you'll see an opacity like this, pretty much like this, where they're sharply demarcated and uniform, almost uniformly. So it's a homogeneous opacity. Okay, so homogeneous opacity like this, where there are certain areas, if you can notice, if I zoom in, if you can notice here, this area is slightly loosened. If you can notice, or should I zoom in further? If you can notice, among all the, or in amidst of all these homogeneous opacities, there is this area which is slightly loosened. Okay, that represents an airway which still has air. Okay, the airway still has air, and that's why it's slightly loosened. On an X-ray, it's a negative film, no? So wherever there is air, it's going to be loosened. Wherever there is something solid, which will block the passage of X-rays, it will be opaque. So here, amongst or amidst all these opacities, you can see this channel where there is still some lucency, and that is what is called an air bronchogram. It's an air, sorry, it's an air bronchogram. Okay. An air bronchogram is indicative of lobar pneumonia, which means there's no air in the alveolus, but there's still air only in the bronchi. So it's an air bronchogram which suggests lobar pneumonia, sharply demarcated borders. So it's confined to certain segments or certain lobes of the lung. That's why it's called lobar pneumonia. Okay, so that is what you see in patients with typical community-acquired lobar pneumonia. Bronchopneumonia, you would end up seeing this kind of nodular opacities. Okay, you see a lot more prominent bronchovascular markings, and you'll see nodular opacities. Okay, that is bronchopneumonia, and it will be present bilaterally. Like for example, in this patient, the opacity is only in the right side, but in bronchopneumonia, it'd be bilateral. A lot of prominent bronchovascular markings along with nodular opacities. Okay, maybe we need to discuss how to interpret an X-ray. How do you describe those opacities? I've just told you about certain descriptions like homogeneous opacities for a lobar pneumonia, nodular opacities, reticulonodular. You can get reticulonodular. Reticular means mesh work or a network. Okay, reticulonodular opacities you can get. especially in interstitial lung disease, right? So maybe we will have a separate session on how to describe the opacities on an X-ray, seen on an X-ray. So, but as I told you, X-ray is very good to try and determine the diagnosis, confirm the diagnosis, but it's not great for determining whether the patient has improved, nor will it be, there'll always be a lag. Okay. So if the patient's pneumonia starts today, the X-ray representative of today's lungs would be present after 2 days. Okay. So that's because the X-ray lag is always going to be there in comparison to the clinical status. So X-ray progression also is delayed and resolution also is delayed on an X-ray. Yet it's very important. Any pneumonia patient, it's a must to do an X-ray. The other investigations are plus or minus, but an X-ray is absolutely important. Okay. Do you need a CT scan for a pneumonia? So it depends. Okay. It depends, especially if you're trying to do a high resolution CT. So you have to think twice before you subject a patient to CT, because it's a very high dose of radiation, especially young patients. So young patients presenting to you, if you're going to subject them to high doses of radiation, that too on a repeated basis, that's going to predispose them to develop malignancies later on. It could end up predisposing. Okay, so you have to be careful. You have to ask for pregnancy status. If it's a young lady who's presented, you have to ask for whether the patient is aware about her pregnancy status. Okay, so nonetheless, if you do need to do CT, it would be in a patient who has an early stage of pneumonia, especially in viral pneumonia. So you all know we used to do, we are used to doing CTs for patients with COVID-19. So viral pneumonias, the exudates are not going to be too much. So hardly any exudates will be there, and you may not pick them up on X-ray. So that is why you do an HRCT, in which you can calculate something called a CORAD score. The CORAD score will help you determine whether the patient has what stage of pneumonia, COVID pneumonia, the patient has. Okay, so viral pneumonias, you can use HRCT. So remember, HRCT, high resolution. So you don't need high resolution for everything. If you can see an obvious opacity on X-ray, you don't need to go in for an HRCT thorax. Okay, just do a CT, plain CT. So you don't need a high resolution every time. A plain CT is enough if you can clearly see opacities on an X-ray. High resolution is important for early stages of viral pneumonia. For it is an investigation of choice for patients with interstitial lung disease. Again, early stages you can easily pick up. When X-ray is not showing anything, the HRCT will pick it up. Okay, likewise in bronchiectasis. Okay, these are the situations where you go for HRCT. Otherwise, an HRCT is not necessary. You can do a plain CT if you wish to do a CT to maybe to try and be able to delineate the pneumonia better. Then in that case, you can do a plain CT. Otherwise, not really necessary. If you're treating a patient with pneumonia, the additional information you'll get from a CT is not much. If your X-ray is showing it, that's sufficient. Okay. Right. Do you need to do gram stain and culture? Only for patients who are hospitalized. So supposing CURB 65 is 0, CURB 65 score is 0, you're not going to hospitalize the patient. Don't subject them to gram stain or culture of sputum. Okay. So just do an X-ray. X-ray is necessary, but not a sputum examination. Not necessary. If the patient is hospitalized, then you can ask them to undergo a gram stain and culture. If the patient is not able to produce any sputum, yet you are behind, you really want to pursue the etiological diagnosis, you want to find out which organism it is, can go for a bronchoalveolar lavage, or if the patient is intubated, then use protected brush specimens or endotracheal tube aspirate. Okay, so if you want to determine the etiology, the organism behind or responsible for the pneumonia, you can try and do these approaches also. Okay, but the thing is, the yield is less. Okay, it's difficult to get a good yield or a positive yield by these methods. So that is why it's ideal, but it's not possible in all situations to try and go for a sputum, grams, or culture. So that's why you do it only for hospitalized patients. Don't expect more than 15% of such patients to have positive sputum culture. Okay, blood culture is even less. I've not even mentioned this. Blood culture, if you want to send, very, very low yield. So you really, even in hospitalized patients, it's not a must. Blood culture for pneumonia, you will get low yield. So earlier, there used to be a misconception that sepsis is nothing but the presence of an organism within the blood. okay, that there is bacteremia. But no, sepsis is not the same as bacteremia. Okay, it's not the same as bacteremia. Sepsis is the dysregulated immune response to a particular infection. The infection may be well within a particular organ. Maybe it's in the lung, maybe it's in the urinary tract. It's not, the organism has not come into the blood. It's just that the immune system is responding in such a way that it's causing problems to itself. That is an dysregulated immune response to a suspected infection, that is sepsis. Okay. So likewise, blood culture being expected to be positive in pneumonia, the chances are less, not high. So you don't really have to keep high hopes from a blood culture. If you really want an etiological diagnosis, you go for a sputum or an endotracheal tube aspirate. Okay, urine antigens, we have options for Streptococcus pneumonia, the polysaccharide antigen test. It has a polysaccharide rate, and pneumococcus has a polysaccharide. That's why patients who are asplenic, I didn't mention this, asplenia, patients who are splenectomized, because spleen is so important in protecting against polysaccharide or capsulated organisms rather. So the polysaccharide capsule, it's taken care of, capsulated organisms are taken care of in the spleen. If a patient does not have a spleen, they need to be vaccinated against capsulated organisms like pneumococcus, like H influenza, and so on. So that is why you can use a polysaccharide antigen test in the urine to try and make a diagnosis of streptococcal pneumonia. Likewise, Legionella pneumonia also, serogroup 1. The serogroup 1 has an antigen test, urine antigen test, okay, which is available. Not very common in India, but in the West at least it is available, so that they can use it for an easier diagnosis, etiological diagnosis of Legionnaires disease. Okay, can any of you tell me what is Pontiac disease? Pontiac disease? Anybody? What is Pontiac disease? Okay, no worries. Pontiac disease is the mild form of Legionnaires disease. So Legionella, it can produce pneumonia. One thing you should know, Legionella flu, very good, Aditya. Legionella flu, very good. So Pontiac disease is a very milder form of Legionnaires disease or Legionella infection. Legionella is capable of producing typical pneumonia. It is capable of producing atypical pneumonia. It is capable of producing hospital-acquired pneumonia. Okay, so all types of pneumonias Legionella can produce. It can even produce typical. We always think that Legionella is atypical, but no, Legionella can produce a typical low, not a classical lobar, but it can produce a more vigorous pneumonia than just an atypical pneumonia. It can also produce hospital-acquired pneumonia. The hospital-acquired pneumonia is obviously because of the AC humidifiers if they get contaminated. Okay, so these are the other tests that you can do. Now, how to decide if the patient requires admission or not? You can use scores. Now, the pneumonia severity index uses 20 indicators, and it divides into class 1 to 5 to try and determine how severe the patient's infection is. So class 4 and 5 definitely end up warranting infection. But the thing is, admission. But the thing is, it is more cumbersome. 20 parameters are there that need to be measured, and that is why it may be a little more laborious. Instead, we have a very easy to calculate curb 65, though not as efficacious as PSI. PSI is more efficacious, but curb 65 is easier to calculate. So most often we end up using curb 65 only. You all know the parameters. Confusion, urea more than 7 millimole per liter, that comes to somewhere around 20 to 21 milligram per deciliter. This is, I'm talking about blood urea nitrogen, I'm sorry. So blood urea nitrogen, which is 20 to 21 milligram per deciliter. That is the rough equivalent or equation of 7 millimole per liter. So if it is more than that, then that counts for 1 point. Respiratory rate 30 per minute or more is 1 point. Blood pressures less than 90 or less than 60, systolic and diastolic respectively. These are again 1 point, and age 65 years or more. This is 1 point. So you get 1 point for each. If the patient has a score of curb 65, if the patient has a score of 0, the person does not require admission. It's an OPD basis. Okay. So you can remember 0 OPD basis treatment, no admission. So if there's no admission, you don't need to do sputum examination. You just do an X-ray just to confirm, and before you send the patient back home. Okay, if the patient has score of 1 or 2, then admit to ward. 1 or 2, admit to ward. Okay, the only exception you don't do it is if this one is because of age being more than 65. Okay, if the score of 1 is only because the patient's age is 65 or more, then it's not warranted to admit. You can still treat the patient on OPD basis. Patient has fever, cough, you heard some crepitations, and the patient is not tachypneic, blood pressures are fine, not in confusion, and blood urea nitrogen is fine, but the patient is 65 years or more, that does not mean the patient needs to be admitted. You can send them on OPD basis treatment also. Okay, so please keep in mind, why is the score 1? Is it only because of the age? Then in that case, send them back home. It's more than that. If the patient has 65 years and above with tachypnea, or the blood pressures are low, or he has confusion, then definitely admit the patient. Okay, 1 or 2 in the ward, 3 and beyond in the ICU. Okay, so you admit to the ICU if the patient's CUB 65 is 3 or beyond. And as the score increases, the mortality also increases. Okay, so that's why that is the basis for CUB 65 being used in determining the severity of the infection and deciding regarding admission. So CUB 65 is a favorite, examiner favorite. So please be well aware about CUB 65. Okay, treatment. Obviously, any patient with pneumonia, take care of the circulation, airway, and breathing. Make sure the patient is not in shock. CUB 65 has 90/60 cutoff. So if the patient is in shock, that needs to be corrected. And first things to do in patient with pneumonia is give them fluids, right? So IV fluid, make sure their crepitations don't increase. Okay, we do want the patient to be hydrated, the shock to be corrected, but you have to be careful. At the same time, you may end up worsening the intra-alveolar fluid or intra-parenchymal fluid of the lungs. So that you have to keep a balance. So give them fluid judiciously. Don't worsen their hypoxia by giving too much or excessive saline support or IV fluids. Okay, oxygen support in the form of nasal prongs, in the form of oxygen masks. Okay, face mask, that is face mask, and you can end up having to use a reservoir bag. You can end up using even the high flow nasal cannula. Okay, so these are the ways you can give them oxygen. If this is not enough, then you have to go for a non-invasive positive pressure ventilation. If not, then ventilator support. So intubation and connecting to the ventilator. So patient is very tachypneic and having a lot of respiratory distress, you may not, or patient is in shock. So when can you not use non-invasive positive pressure ventilation? The advantage of NIPPV is you avoid ventilator associated pneumonia, but NIPPV cannot be used if the patient is in shock. So contraindications for non-invasive positive pressure ventilation: if the patient is in shock, or if the patient is having low GCS, drowsiness, cannot protect his or her own airway. If the patient's airways are compromised, patient is drowsy, cannot put them on NIPPV. Okay, you need to intubate, protect their airway, and connect them to a mechanical ventilator. Okay, so these are the other aspects that you need to make sure you cover for pneumonia in terms of treatment. But mainly, of course, it's an infection, therefore you need to be starting them. Oxygen support really help. Does elevated PO2? Yes, I mean, oxygen support definitely helps. Now the whole thing is the person's the patient is having respiratory failure. That's the reason why the PaO2 has dropped, and as a result of that, what is going to happen? It's going to trigger tachypnea. The person is going to start breathing very, very fast. So any patient who has tachypnea, finally, these are all skeletal muscles. Okay, so whatever muscles you are using for breathing, including the diaphragm, these are all skeletal muscles. So they have a capacity beyond which they can't continue. So they will reach a point of fatigue. You have to at all costs avoid that point. So if it comes to a point where the respiratory muscles have reached so much fatigue that they can't continue, patient is going to be at risk for respiratory arrest. So well before that, you should have intubated the patient, and even before that, you can give them oxygen support just to give them give their respiratory muscles a little bit of rest. so that they don't need to work as hard to try and maintain their PaO2. So if you're giving them oxygen support, when you give them oxygen support, you increase the FiO2. As soon as you give them oxygen support, you are increasing the fraction of inspired oxygen. So that will help in increasing the PaO2 also. So the amount of alveolar oxygen content will increase. That will allow whatever little normal lung is left. Let's say there is extensive pneumonia, both lungs, a lot of segments are involved, a lot of alveoli are damaged. But whatever few normal ones are left, they can allow more amount of oxygen to go into the blood so that the hypoxia is corrected. And that will relieve the work of breathing. The respiratory muscles will get a rest, will get a break, and therefore you can postpone at least the need for ventilator and all. So definitely oxygen support is required as long as the patient has hypoxia. If the PaO2 is low, okay, if a person has less than 92% PaO2, oxygen saturation, if the SpO2 is less than or equal to 92% on room air, the person needs to be hospitalized. This is also an indication for hospitalization actually. It's not there in CUB 65, but if the saturation, peripheral pulse oximeter saturation is less than 92%, less than or equal to 92%, then the patient needs to be hospitalized. Okay, they can progress very rapidly. That is the issue, especially like H1N1 and all. No, there are some seasons where the disease is, or you remember COVID. So how relentless the COVID infection used to be. COVID was an exception, of course. There used to be something called happy hypoxia. Even though the person's saturation was low, the person would not realize, they wouldn't have symptoms of tachypnea. But otherwise, most other infections, they will definitely have features of tachypnea, will have respiratory muscle embarrassment. So all that needs to be avoided with oxygen therapy. Okay. Empirically, antibiotic therapy depends on how the patient's pneumonia is. Is it severe? Is it non-severe? Does the patient need to be treated on OPD basis or need to be hospitalized, as well as any risk for antibiotic resistance? Okay, so non-severe OPD basis treatment, you can go for beta-lactam like amoxicillin with macrolide combination. So macrolide like azithromycin. So what we generally do is put them on amoxicillin plus azithromycin and send them home. Okay, so you can complete a 5-day treatment. You've done an X-ray, it's not showing extensive disease, and the CUB 65 is 0. So you're sending them home. You don't need any other tests. Just send them on a combination antibiotic. What this will do is it will take care of the typical and most atypical. Okay, so atypical bacteria are covered by the macrolide, whereas the typical ones are covered with beta-lactam. Sometimes if there is a suspicion for Staph aureus, you need to add cover for that. But most Staph aureus pneumonias will not be non-severe. They will be severe. Okay, so Staph aureus pneumonias generally will not be non-severe. So this is what you start them on if you're disposing or rather discharging or sending them home, basically, not admitting them for their pneumonia. If the patient needs to be hospitalized, if the CUB 65 scores are 1 and beyond, needs to be hospitalized, then in that case, you can again start them on the same combination, beta-lactam plus macrolide, the same combination. You can also choose monotherapy with fluoroquinolones, respiratory fluoroquinolones. So respiratory fluoroquinolones, these include levofloxacin, gatifloxacin, as well as you can use levofloxacin or gatifloxacin actually. And these are respiratory quinolones, but we don't use them frequently for monotherapy of pneumonia, because in our country we have a bigger headache of tuberculosis, and these are our second line agents, right? So we need the quinolones as reserve drugs for treatment of tuberculosis. That's why in our country we don't use quinolones as monotherapy for pneumonia unless we have no other choice. So that's why it has to be discouraged. We don't use quinolones for treatment of pneumonia. We use it for tuberculosis, especially patients who have developed drug-induced hepatitis, ATT-induced hepatitis. These become a very important way of overcoming that. Okay. If there is a risk for antibiotic resistance, what are the risk factors for antibiotic resistance? A patient who's, as I said, old age home or a nursing home resident, okay, old age homes, because multiple patients, multiple elderly people would have had different strains of bacteria with different treatments themselves. So there is always going to be a risk for those organisms having developed a multi-drug resistance by interacting with each other. Okay, or if the patient has had recent antibiotics. So antibiotic exposure in the last 90 days, in the last 3 months, antibiotic exposure is also a risk factor for antibiotic resistance. Okay, antibiotic resistance or rather exposure in the last 90 days is also a risk factor for antibiotic resistance, especially for pneumococcus. Okay, so pneumococcus can end up developing antibiotic resistance if they have produced an infection in a patient who had received antibiotics at any time in the last 90 days. I'm sorry. In hospital acquired pneumonia, Arjun's asking, organism would be expected to have resistance to beta lactams. Yes, very true, very good. So in both hospital acquired pneumonia and in healthcare associated pneumonia, the chances of resistant organisms is high, or higher than community acquired at least. So how we'll have to consider it is VAP has highest risk in comparison to hospital acquired pneumonia in terms of resistance, and then community acquired pneumonia. Okay, so definitely hospital acquired pneumonia is greater than community acquired pneumonia in terms of risk of having drug resistance, because the person was breathing the hospital air when the person developed the pneumonia. So hospital air will definitely have organisms which will be expected to have multi-drug resistance or drug resistance at least. Okay, so very true. Why do we use beta lactam as treatment of hospitalized? Yes, so if you're using in as I was about to complete, risk of antibiotic resistance, if you're anticipating oh no, you meant this, is it? Okay, okay. No, I didn't mean hospital acquired pneumonia. I meant a patient with community acquired pneumonia who's getting hospitalized. So if the patient who has severe enough pneumonia to require hospitalization, if the curve 65 is 1, 2, 3, 4, if such patients are getting hospitalized, then we start them on a combination of beta lactams to cover for the typical organisms and macrolides for atypical organisms. If they develop hospital acquired pneumonia, or if you have any suspicion of antibiotic resistance in the first place, then you need to add beta lactam plus beta lactamase. Okay, so if you're using amoxiclavulinate, so clavulinate you add on to try and deal with the antibiotic resistance. Along with this, if there is any risk for staphylococcus pneumonia, so along with these, for staphylococcus pneumonia, you will have to add either linezolid or vancomycin, preferably linezolid more than vancomycin. Okay, usually we prefer linezolid. That's because there are both IV and oral forms of linezolid. The bioavailability is 100% for linezolid. You can give the same dose IV, you can give the same dose oral. So it's easier to convert. Vancomycin, we don't have oral vancomycin for systemic infections. We have oral vancomycin only for treating the antibiotic associated diarrhea. That means Clostridium difficile diarrhea. But otherwise, we don't have systemic infections, vancomycin oral therapy. Okay, so staphylococcus, we start with linezolid or vancomycin because we expect them to be MRSA. Staphylococcus aureus, we invariably will encounter as MRSA if you're thinking of resistant staph. Okay, and in terms of Pseudomonas is always going to have intrinsic resistance to beta lactams, but there are certain beta lactams which work against Pseudomonas, like ceftazidime, like cefoperazone, or even cefepime, the 4th generation, and beyond that. So piperacillin, tazobactam, meropenem. Okay, so basically ceftazidime, cefoperazone, and cefepime, along with meropenem. Meropenem is a carbapenem, or piperacillin tazobactam. All these have anti-pseudomonal effects or actions. So therefore, if you're suspecting Pseudomonas, if the patient has a COPD or a bronchiectasis, has previously had Pseudomonas infection, the patient with a structural lung disease, once that Pseudomonas gets access, it is not going to go away. Even if the disease has come down, the infection still stays, it lingers behind. So if in future also, if they develop a pneumonia, our first thought is that it still must be Pseudomonas. So if there was a previous history of Pseudomonas being isolated, the next episode also you will suspect the patient to have Pseudomonas only. So in that case, please do add anti-pseudomonal coverage. You also add anti-pseudomonal coverage, not just for drug resistance, for patients with neutropenia. Okay, neutropenia patients also you add anti-pseudomonal coverage. Okay, because neutropenia is a big risk factor for Pseudomonas infection. Okay, so this is regarding how you would empirically treat patients with pneumonia. Beyond this, you will ask for a culture of the sputum or the endotracheal aspirate, and once the culture report arrives, you can switch back to specific. You can de-escalate and give specific treatment. Okay, so depending on what the culture grows. So if you notice, we don't get enterobacteria very frequently. We don't get E. coli producing pneumonia, not in adults. We get it in children. Of course, in the neonatal period, one of the more common causes of pneumonia are E. coli, but you don't get very frequent enterobacterial pneumonia in adults. Okay, so one question arises: if you treat the patient and still the patient's not getting better, there could be an alternate diagnosis, not just pneumonia. It could be a malignancy. Okay, it could be a vasculitis, for example, granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis, hypersensitivity pneumonitis. There are acute forms of hypersensitivity pneumonitis, so that could be confused for a lower respiratory infection or inflammation like pneumonia. Eosinophilic pneumonia is a non-infective cause of pneumonia, not going to respond to treatment. Pulmonary embolism. So submassive pulmonary embolism can masquerade as a pneumonia. So submassive pulmonary embolism could be a differential for non-resolving. You tried treating, didn't get better. The patch is still persistent. Patient's symptoms of cough is still there. Could be any of these. Okay, so consider them. In such cases, you can go for a CECT. So do a CECT, find out where it is, what it is. If you can localize it, then try and go for a biopsy. You can go for a biopsy either by doing a bronchoscopy, or if it is superficial enough, you can do a CT guided biopsy. Okay, so you can localize using an initial CCT. If it is quite central, if it's a central lesion, you can go for a bronchoscopy and then do a biopsy. If it's a peripheral lesion towards the chest wall, you can do a CT guided biopsy itself and then confirm what the diagnosis is. Okay. Right. A word on vaccines. How do you prevent the pneumococcal infections? So we have PPSV. I'm sorry, this is PCV. This is a mistake. It's not PPSV. It's PCV, pneumococcal conjugate vaccine. Okay, pneumococcal conjugate vaccine 20, PCV 20, or you can do a combination of PCV 15 with PPSV 23. So pneumococcal conjugate vaccine is PCV. Polysaccharide or pneumococcal polysaccharide vaccine 23 is PPSV 23. Okay, so I just mention here pneumococcal conjugate vaccine is PCV, and pneumococcal polysaccharide, the same polysaccharide which we talked about, it's present in the capsule. You use it in the urine for antigen testing also. That is PPSV 23. So 23 strains of pneumococci, the common 23 ones, their polysaccharide would be used to make vaccine. That's called PPSV 23. And pneumococcal conjugate vaccine, these are actually, earlier we used to use 13, then it became 15. And now what is recommended right now by CDC is a single PCV 20 is sufficient. You don't need even a combined PPSV 23. So pneumococcal conjugate vaccine 20 strains of pneumococci, their conjugate vaccine is sufficient as a single vaccine for preventing pneumonia. So when is it advised? That magic number of 65 comes again. Anyone age 65 years above, curb 65, that's why it's considered as an important parameter. So 65 years and above is an indication for vaccine with the pneumococcal vaccine. Alcoholism and cigarette smoking are other risk factors. CSF leak, chronic heart disease, except hypertension, chronic liver disease, chronic lung disease, COPD, bronchiectasis come to mind. Okay, and cochlear implants. So any patient who has cochlear implant also, they suggest that the patient undergoes an uncontrolled diabetes mellitus, again an indication for pneumococcal vaccines. Okay, and then all the immunocompromised conditions, again the slide has missed off, but anyone with HIV, anyone who has congenital immunodeficiencies, okay, congenital or acquired immunodeficiencies, organ transplant, acquired immunodeficiency, organ transplant patients, all these are again indications for, because these are not live vaccine, you should be giving them. Splenectomy patients, so splenectomized asplenic patients, Patients with sickle cell disease patients invariably develop functional asplenia because of autosplenectomy. So all these patients, you can recommend them to have vaccines. So this is pneumococcal vaccine. We also have vaccines against influenza, viral influenza, and we have vaccine against H influenza B also. So if a patient is having recurrent pneumonia, you can suggest, especially patients of COPD. So anytime you see a patient of COPD, you're treating them, you know that they're prone for recurrent acute exacerbations. So please vaccinate them against both pneumococcal vaccine and influenza virus. Additionally, you can give them H influenza B also. Are these the indications? Sinjana is asking, these are the indications for above mentioned vaccines? Yes. Yes, these are the indications for the pneumococcal vaccines. What I've mentioned here, all these are indications for pneumococcal vaccines. Additionally, even influenza viral vaccines. Okay, so influenza viral vaccines are also indicated for those who are aged 65 and above, 65 years and above. So these are the indications for pneumococcal. Additionally, even influenza virus vaccines can be given to patients who are 65 years and above. H influenza B is not universally recommended, not even for adults above 65 years. You can give them, it's an optional vaccine currently. Currently, it's not necessarily or compulsorily advised. Instead, if a patient again has all these, whether the patient has been splenectomized, patient with nephrotic syndrome, patient with nephrotic syndrome, they very frequently develop capsular organism infections. So such patients, you can offer them H influenza B vaccine additional to pneumococcal and influenza viral vaccine, and all these immunocompromised patients also. So all of these are not live vaccines, therefore you can suggest them to these patients. Okay, so so anyone, these are the remaining ones. No, only the first one is obviously for those who are 65 years and above. All the other indications are if the patient is less than 65 years age. Otherwise, automatically, as soon as the patient becomes 65 and above, patient needs to be given pneumococcal. Okay, fine. This slide hasn't come out well. Nonetheless, so summarizing, we have different etiologies for typical and atypical. Typical is mainly organisms like, the most common is of course pneumococcal, but again you have other organisms like H influenza B and Staphylococcus aureus and Legionella also. So Legionella, remember, can produce typical and atypical both. Okay, typical and atypical both can be because of Legionella. So etiology wise they're different. Right. Pathology wise, again, low bar picture for typical, and atypical will be usually interstitial. Okay, usually interstitial. And clinical feature wise, high fever in typical, they'll have productive cough. Okay, sputum will be there. Whereas in atypical, they will have low grade fever, they will have dry cough, and a lot of extra pulmonary manifestations may be there. Okay, dry cough and extra pulmonary manifestations. Investigation wise, again, leukocytosis is expected, and on an X-ray, you'll expect that the patient has a typical consolidation or a lobar pattern, whereas interstitial pattern for atypical. Interstitial pattern for atypical. And treatment wise, you target typical organism with the beta lactams, whereas you use atypical coverage, either use macrolides or fluoroquinolones, but in our country, we don't use fluoroquinolones, we use macrolides. Okay, doxycycline is another alternative for atypical organisms. Okay, so Mycoplasma pneumonia is the most common cause of atypical pneumonia. Mycoplasma pneumonia is the most common cause of atypical pneumonia. It doesn't have a cell wall. So you can't use cell wall inhibitors like beta lactams. You have to use either macrolides or quinolones or tetracyclines like doxycycline. Okay. Just quickly, I'll wrap up in 5 minutes. Quickly, I'll finish off the other types of pneumonia. I already told you aspiration pneumonia is not necessarily because of a macro aspiration, or rather community-acquired pneumonia is not necessarily because of macro aspiration, but there is a term called aspiration pneumonia. It's mentioned in your CBME curriculum, so you need to be knowing it. Expect a 5-mark question on aspiration pneumonia. This occurs because of obvious spillover of either oropharyngeal content or gastric content into the lungs. Gastric content Apart from H. pylori, it may not have too many bacteria, but oropharyngeal definitely has a lot of bacteria, including anaerobes, streptostreptococci. What are the risk factors for altered sensorium, or rather, what are the risk factors for aspiration? This include altered sensorium, dysphagia. Dysphagia could be neurogenic, like a bulbar palsy, vocal cord palsy, or a patient who has mechanical obstruction. Patient has a, let us say, an achalasia cardia or a diverticulum that is present, or a very severe GERD. These are all risk factors for aspiration. Near drowning, of course, is an environmental risk factor, and volatile poisons like kerosene. So these volatile hydrocarbon compounds, these could also end up producing chemical aspiration pneumonia rather than an infectious aspiration pneumonia. Otherwise, most often we think of aspiration in a patient who is having low sensorium or altered sensorium. That is why we go for intubation. We protect a patient who is comatose. We protect their airway by intubating them so that they can protect. We can prevent aspiration pneumonia in them. Okay, so aspiration pneumonia will definitely have anaerobes if the oropharynx or the dental hygiene is compromised. So dental hygiene is important. If the patient has poor dental hygiene, then definitely risk of anaerobic infection is high. In that case, you need to give anaerobic coverage. Okay, so otherwise the etiology is not very different from community acquired or nosocomial pneumonia. So depending on where the aspiration happened, was the patient being cared for at home? Supposing a patient with stroke, patient had a stroke, he was taken back home, but the sensorium never improved, and maybe another 4 months or 5 months down the line, that he developed an aspiration. So that becomes, the etiology becomes very similar to the organisms will be expected to be similar to community acquired pneumonia. Okay, likewise, if the aspiration happens within the hospital, then it becomes a nosocomial aspiration pneumonia. So the etiology organisms are not very different from these settings. Okay, the risk of anaerobes is there, but it's minor, especially if the patient has poor dental hygiene or if the patient has developed a lung abscess. Okay, now the segments which are most commonly involved, this is more of an entrance exam question. You know that the right lung is always more involved than the left lung in aspiration pneumonia, and that is because the right main bronchus is almost in direct continuity with the trachea. So this is how the trachea bifurcates. It's almost in direct continuity. Okay, whereas there is a more acute angle in comparison to the right bronchus with the left bronchus. So left bronchus is more acute. Right is almost in continuity directly with the trachea. It's wider also. Okay, and therefore there's a higher risk of aspiration into the right lung rather than into the left lung. Okay, and among the segments, the most common segment involved is in supine position. If there's aspiration, it's the superior segment of the right lower lobe, and in upright position, it is the posterior segment of the right upper lobe. Okay, right lung upper lobe. So superior, remember, supine is superior segment of the right lower lobe. These are the segments involved more commonly. As I said, coverage need not have to be including anaerobic cover. It's not always, unlike what we used to think previously, aspiration does not really encourage anaerobes unless there is poor dental hygiene, or if already there's an abscess or a necrotizing pneumonia in the lungs. Okay. Yeah, this has gotten reversed a little bit. Anyway, a 45-year-old man has threatened to sue a hospital because he suffered from pneumonia following his admission for daycare cataract surgery. So, the patient is angry at the doctor, saying, "I am suing you." And that's why the doctor is surprised. But he says, "Because I got hospital acquired pneumonia after daycare surgery." So this is the doctor's reaction. Why do you think the doctor is relieved? The hospital acquired pneumonia after daycare surgery. Very good. Jayalakshmi is answered it correctly. It's within 48 hours. So daycare surgery, that means the patient's not been admitted even for 24 hours. That means the patient cannot blame a pneumonia or any infection for that matter on the hospital. The patient should have developed the infection after 48 hours of admission. Otherwise, it cannot be attributed to the hospital. It's just a patient who was harboring community acquired infection, which manifested later. That's all. Okay, so hospital acquired pneumonia is another entity. 70% of such infections happen outside of the ICU, 30% within the ICU, and within the ICU we get a lot of VAP. Ventilator associated pneumonia is a very typical, very specific type of hospital acquired pneumonia. Okay, diagnosis can be difficult because already they would have been hospitalized with some other condition. Therefore, there will be a lot of overlap. Maybe missed a lot of times. So you may miss the hospital acquired pneumonia because of overlapping comorbidities, comorbid conditions, and pre-existing comorbidities. Yes, so that's what actually also leads on to a risk for developing hospital-acquired infections, including hospital-acquired pneumonia. So if a patient has been admitted for 4 or 5 days for some other condition, non-infectious condition, and then develops fever, you always think of hospital-acquired infection, out of which hospital-acquired pneumonia has to be one of the differentials. Okay, the patient may already have comorbidities due to which they'll have poor cough, poor respiratory movements, and they'll be prone for macro aspiration. So remember, in hospital acquired pneumonia, the risk of macro aspiration is more. In ventilator associated pneumonia, micro aspiration is more. Okay, so hospital acquired pneumonia, macro aspiration risk is higher. Okay, so because the pre-existing comorbidities, already they'll be very sick, they'll be hospitalized, and on top of that, they may end up having aspiration, macro aspiration. Okay, what about this case scenario? A 30-year-old man with acute flaccid ascending quadriparesis intubated due to respiratory muscle weakness. 5 days later, but before we proceed, what is the diagnosis for this much? Acute ascending quadriparesis, flaccid quadriparesis. What is the diagnosis involving the respiratory muscles also? GB syndrome, very good, Jay Lakshmi. Very good. GB syndrome. 5 days later, developed fever. So he was intubated because the respiratory muscles had become weak. Then he developed fever. Yeah, and an increase in oxygen requirement. There were crepitations noted in the right memory area, and this was the X-ray. So you can note that compared to the left side, the right side, there are opacities in the mid and lower zones. So in X-ray, we divide them into zones. So this X-ray is suggesting that there is some opacity there. Okay, so the suspicion, what would you call this? Patient has been intubated, correct, Arjun? GBS, very good. Intubated patient for non-respiratory infection indication. So patient didn't have respiratory infection to begin with, was intubated because of respiratory muscle weakness, now developed fever, increased oxygen requirement, and opacity on the X-ray. The diagnosis is technically aspiration pneumonia. True. So again, aspiration pneumonia is like an umbrella term. As we discussed, even in hospital acquired pneumonia, there can be aspiration. Community acquired also there can be aspiration. But here the term is patient has been intubated. So this is the endotracheal tube, you can notice. He's been intubated, and then very good. Since I said GBS with VAP, ventilator associated pneumonia. Yes, correct. So it is ventilator associated pneumonia, and that is because patient's been intubated. So what's happening? Why are you going to intubate we always talk about protecting the airway. So when we intubate, we are protecting the airway, thinking that we are doing what the epiglottis is failing to do. So epiglottis is supposed to protect any oropharyngeal or gastric contents from coming back into the lungs. The epiglottis shuts and doesn't allow these to pass through. So if a patient is comatose or for some reason the epiglottis is compromised, you intubate the patient, and therefore we feel that we are protecting the airway, right? We're doing what the epiglottis would have failed to do. We are inflating this cuff. Okay, in this picture, the cuff is not inflated yet, but you are going to inflate this cuff, and because it will occupy the lumen of the entire lumen of the trachea, we are thinking that this is going to protect from aspiration because it's going to block any secretions from coming like this, right? From outside the tube, anything that comes will be blocked by the cuff, because now we have passed the tube through the epiglottis. The epiglottis cannot close. Even if you wanted to, the epiglottis cannot close. So we need to protect anything that leaks through this area outside of the tube from coming in, and that is by inflating this cuff. But the problem of doing this is when the cuff is inflated, there's a lot of pooling of secretion that happens here. Okay, a lot of secretion keeps coming slowly, trickles down and gets pooled here. And when there's pooling of secretions immediately above the level of the cuff, it will slowly start getting aspirated. Okay, there are micro aspirations. That's why I was saying ventilator associated pneumonia is because of micro aspirations, whereas hospital acquired pneumonia is because of macro aspirations. So slowly this will start trickling down. So this will increase as the time duration of intubation increases. The longer the person is on ventilator, the higher the risk of pneumonia, ventilator associated pneumonia. Okay, so that is why what we can do to try and prevent this kind of pneumonia is to attempt to keep the duration of ventilator requirement to the minimum. Okay, if the patient can be extubated and be taken off the ventilator, we should attempt it at the earliest. So try and be aggressive in extubating. You have to keep in mind, why did you intubate in the first place? Maybe the disease process has still not resolved. The disease hasn't still resolved. You may not be in a position to take them off the ventilator, but you can still remove the tube. So taking the tube out itself is a big advantage in preventing ventilator associated pneumonia. What I mean is, take out the tube and do a tracheostomy. Put a tube here. So when you put a tube here as a tracheostomy tube, you will allow the epiglottis to close now. Now the epiglottis will close, and any aspiration can be prevented at this level itself. Along with that, of course, here also there will be a cuff. For the tracheostomy tube also there will be a cuff. So you are preventing aspiration at two levels. Both epiglottis will also work, and even the cuff will be in place. So tracheostomy, early tracheostomy is one of the ways you can reduce the risks of ventilator-associated pneumonia. Beyond that, of course, see, now there is always a risk of gastric contents developing bacterial growth because of pH being high. So normally pH is low. That's why the stomach doesn't have too many bacteria, only H. pylori mainly. But if you are going to increase the pH by giving proton pump inhibitors, you may encourage gastric colonization. And that, if it starts refluxing, might gain access into the lungs and produce ventilator-associated pneumonia. So indiscriminate use of PPIs needs to be checked. Likewise, maintaining good oral hygiene. So oral contents can also end up getting aspirated in a patient who has an endotracheal tube. So maintaining as best oral hygiene as possible will also help. Beyond that, all the healthcare workers should maintain good hygiene and hand sanitization when they handle all the ventilator associated equipment and the endotracheal tube. Okay, so these are all the aspects regarding ventilator associated pneumonia. Non-MDR pneumonia predominates in the non-multi-drug resistant pneumonia predominates in the first week, and MDR pathogens start creeping up in the beyond the first week. Okay, and especially the risk factors for MDR pathogens are multiple antibiotic use. If the definition of MDR in terms of ventilator-associated pneumonia is if there is resistance to 3 or more classes of antibiotics. With 3 or more classes of antibiotics, if there is resistance, it is MDR, considered an MDR pathogen. So what are the risk factors for ventilator-associated pneumonia? Oropharyngeal colonization. So we need to maintain good oral dental hygiene. So dental care is important. So nurses are always instructed to maintain proper adequate oral hygiene. Micro aspiration, as I said, in comparison to hospital-acquired pneumonia, where there is macro aspiration. And immune response will be suppressed, of course, because any sick patient, if they ended up going on to the ventilator, their immunity is probably already quite low. That is why there is for ventilator-associated pneumonia. Okay. And these are the clinical features. Patient who's on ventilator, who develops fever, who has increased intratracheal tube secretions, who has a sudden jump in oxygen requirement on X-ray if there's a new patch, and inability to wean from the ventilator. So patient's original illness has gotten better. The GB syndrome got better, and still you're not able to extubate them because they've become dependent on the ventilator. It could be because they've developed a ventilator-associated pneumonia. So one of the differentials you should consider, if you're not able to wean a patient off of the ventilator, it could be because of a ventilator-associated pneumonia. Okay, so I'm sorry I've taken so long. I perhaps took a little too long to explain everything, but I'll end with these 3 MCQs. Please bear with me for 3 slides. First MCQ, it's a young man, 20-year-old man, 4 days, low-grade fever, headache, dry cough, myalgia. Many of these words are very, very key points, right? So temperature is 38 degrees, low-grade fever, not much. Heart rate seems okay. Respiratory rate seem okay. Saturation on room air okay. Shin has erythematous tender nodules. Chest auscultation has faint crackles. Which of the following is the likely cause of the infection? Is it H. influenza B, Mycoplasma, Pneumococcus, or Pneumocystis jirovecii? Any idea? Any Guess is B. Jayalakshmi said B. Sinchana says mycoplasma. Sila says B. Very good. So all of you are correct. Arjun also says B. Very good. So there's only one atypical organism mentioned technically. Even pneumocystis jirovecii may be considered as a cause for atypical pneumonia, but then in a 20-year-old where there is no mention, no obvious cause for immunocompromised status, so pneumococcus jirovecii will not produce pneumonia in an immunocompetent individual. So unless there's an obvious history or obvious feature pointing towards immunocompromised status, this cannot be pneumocystis. And this additional feature of erythematous tender nodules, so mycoplasma can be associated with a extrapulmonary manifestations, one of which is this is as the term itself suggests, erythema nodosum. So erythema nodosum, tender nodes or nodules which are erythematous, which occur on the shin. This is an extrapulmonary manifestation of mycoplasma pneumonia. Very good, all of you got that right. Second MCQ, antibiotic use within the last dash days predicts a risk for antimicrobial resistance for pneumococcal pneumonia. Is it 15, 30, 60 or 90? 90, Sinchana says 90. Very good. Actually, Sinchana is correct. It is 90 days. So anytime in the past 90 days, if a person has received antibiotic and then goes on to develop pneumonia because of pneumococcus pneumonia, the chances of that particular strain of pneumococcus having antibiotic resistance is high. That means it has emerged within 90 days of a previous antibiotic use. That means it must be resistant, right? So within 90 days, if a patient of an antibiotic use, if a patient develops an infection, you will have high doubts that this patient must have, this particular strain of bacteria must have resistance against that antibiotic. Okay, so you're very much correct, Sinchana. Last MCQ, 70-year-old present with the sore throat, cough since 3 days. Blood pressure is fine. Respiratory rate is just about fine. The GCS is 15/15, which is normal. Chest auscultation reveals crackles, bilateral infrascapular areas. Blood urea is 30. 30 is okay. This is blood urea, okay, but not blood urea nitrogen. So blood urea is of 30 is absolutely okay. Upper limit is 45 actually. What is appropriate for him? Is it that the patient requires hospitalization? So basically, for that, you'll have to check the curve 65. If you notice here, patient not having confusion, GCS 15, urea is fine, respiratory rate is not above 30, blood pressure is fine. 65 age, yes, he is crossing it. But as I said, if it's only that one point because of which the curve 65 has not 0, it's 1, then that itself does not warrant admission. So patient need not be hospitalized, can be treated on OPD basis just because of the curve 65 itself. What about amoxiclav or rather amoxicillin plus levofloxacin? So a combination of amoxicillin and levofloxacin is reserved for severe pneumonia who are admitted, severe hospitalized pneumonia patients who have antibiotic resistance. Patients with antibiotic resistance who have severe pneumonia and are hospitalized. I'm sorry, antibiotic resistance. Okay, and therefore, either you need to give them amoxicillin with levofloxacin, or you can give them amoxicillin with macrolide. That is for antibiotic resistance. Okay, amoxiclav with macrolide. I'm sorry. So this is not the most appropriate answer. Sputum culture, again, sputum culture, as I said, not required in a patient who's not getting hospitalized. OPD basis treatment does not warrant sputum culture. Chest X-ray, yes. Every patient of pneumonia, whether it's curve 65 0 or curve 65 of 5, you have to advise for a chest X-ray. So chest X-ray is absolutely warranted. Okay, very good. I'm glad you guys have stayed with me and answered so nicely. Thank you very much for your